Hi all, thank you for taking your time out of your day to meet for this journal club. So today I'll be presenting the article titled Disparities in Spatial Access to Emergency Surgical Services in the United States. This article was recently published in October of last year, and the authors listed are associated with various departments of the University of Utah, Salt Lake City. All right, so as the background, it is estimated that 46 million United States residents live in rural areas in 2020, making up to about 14% of the total US population. Residents who live in smaller and more isolated rural settings often face greater difficulties accessing provisions and health services, among other economic and social challenges. Issues in healthcare access for rural residents have mostly been examined via studies focusing on accessibility, such as distance or travel time to healthcare provider or hospital. However, such studies may not explore hidden variables that fuel disparities in healthcare access, often seen in rural populations when compared to urban populations. Most studies focus on primary care access, few of them focusing on surgical care access for these populations. Diseases that require emergency general surgery intervention constitute a growing public health burden in the United States. These include, but are not limited to, appendicitis, cholecystitis, and perforated bowels. They tend to cost more than $28 billion a year and are the reason for more than half of all surgical mortalities. So how do different regions in the United States compare in emergency surgical access? So the novel thing about this study is that it's the first published study that examines spatial access to emergency surgical care in the United States at the census block group level, using a state-of-the-art enhanced two-step floating catchment area method that is known as spatial access ratio. This is used to assess access of population to emergency surgical care. This method basically uses weighted ratios of hospital capacity, patient volume, and travel distances and time to provide an analyzed level of access to healthcare systems based on multiple factors. The goal of the study the goals of the study are to evaluate the spatial access to any emergency general surgery capable hospital, to assess access to hospitals with advanced clinical resource only, because management of complicated or severe diseases may necessitate resource primarily restricted to these hospitals, and to evaluate sociodemographic characteristics of communities at high risk for limited access to emergency surgical care. So the authors hypothesized that substantial population disparities exist in access to overall and advanced resource hospitals may exceed those previously reported, and that race and ethnicity play a vital role in these disparities in spatial access to surgical care. So this is a cross-sectional study. The geospatial data and hospital selection were based off of the American Hospital Association 2015 annual survey database and lists of trauma centers from the American College of Surgeons. To define the emergency general surgery capable hospitals, the authors looked at hospital clinical resources and measures of utilization. They also looked at all non-federal general service hospitals, then excluded limited service hospitals and those that perform less than 10 surgical cases annually, and any hospitals without emergency services. They also cross-referenced this with the American College of Surgeons Trauma Center list to capture additional hospitals not included in the AHA annual survey database. Hospitals were classified as having advanced resources if they had at least 5 general intensive care unit beds, and had a CT scanner, ultrasound, and advanced gastroenterology services, or perform more than 2,700 procedures annually. These resources were selected for the relevance to management of complex emergencies of general surgery. So geospatial data such as zip codes, city boundaries, and transportation networks were gathered from the Environmental Assistance Research Institute. So the spatial Spatial access ratio, or known as SPAR, is a ratio of a given place's access score to the mean of all access scores in the study area. Here it was calculated using measurements of supply, demand, and travel impedance. Supply or hospital capacity was measured using the number of inpatient hospital beds. Demand was approximated by the population of each census block, and they set the catchment area to about 60 minutes of driving time, as this represents a common benchmark that's used for access to care. The spatial access ratio is based on the national average and ratio comparison with census block group to this average. Therefore, a value of 1 equates to a national standard value, and those with greater than 1 would indicate a higher access to surgical care, and those with a value between 1 and 0.3 as moderate access, and those less than 0.3 would indicate low access. So the sociodemographic characteristics that was examined from the American Community Survey were from 2013 to 2017, and they included population size, race and ethnicity, poverty rate, health insurance coverage, and rural or urban status. These factors were utilized in the multivariate statistical models of the study to assess for associations. So sociodemographic disparities in spatial access were examined with census block group as the unit of analysis. A total analytic sample of 210,562 census block groups was used. Multinomial regression models assess the association of demographics, and multivariate regressions were used to assess association of census tract demographic characteristics. Adjusting for median age, race and ethnicity, as well as income and health insurance coverage. Models were then constructed for the following areas that include metropolitan, micropolitan, and rural to assess the demographic differences within these categorized regions. So here's a figure included in the study, which shows the number of advanced emergency general surgery capable hospitals, those hospitals that are able to handle complex surgical cases, indicated by the blue dots on the map. And the basic emergency general surgery capable hospitals are indicated by the red dots. As you can easily tell from this image, most of them are located in the eastern half of the United States, condensed mainly in the northeastern United States, especially the advanced emergency general surgery capable hospitals. So they did start with about 217,663 census groups. However, they excluded about 7,000 due to missing information. The median age of the population of these groups analyzed was about 39.7 years. And within the United States, they found that there is about 3,853 hospitals that have emergency general surgery capabilities. So of the 320 million Americans, they found that 134 million people have great access to emergency general surgery capable hospitals, indicating a SPAR that's greater than 1. However, 30.8 million people, or about 9.6% of the US population, experience low access to emergency general surgery capable hospitals, as indicated by the results of SPAR that were less than 0.3. And of those, 8.7 million people were found to be in the lowest identified category, which was a SPAR less than 0.1. Of the 1,000 or so advanced resource hospitals, those able to handle complex surgical cases, 82.6 million, or about 25.8% of the United States population, had low access to these hospitals. And of those, about 16% of the US populations had the lower SPAR category. So looking at the big picture, the Northeast population overall had the greatest access to any emergency general surgery capable hospital compared to the West, and the South, which actually had the lowest access. In regards to advanced surgical hospitals, the Northeast again had the greatest access, and the Midwest in this case had the lowest access. So when they performed a small area analysis, they noticed that those communities of lower access were older, had a lower proportion of Black and Hispanics, and smaller ratio of ethnic minorities in the communities. They were also poor. The majority of these communities were rural and made up 36% of low access communities. However, interestingly enough, about half of low access census block groups were classified as metropolitan areas. So when you look at metropolitan areas, you can see a higher number of uninsured patients and those publicly insured, which include Medicare and Medicaid and Medicare, as well as governmental coverage. And these patients had an increased risk of being low access. Looking at population characteristics, it showed that there is a greater risk of being low access if you're Hispanic or from another race or ethnic minority in micropolitan or rural areas. The most pronounced effect is in micropolitan Hispanics, who have nearly threefold risk of falling under the low access categories. So if you look at the Northeast, it does show that there is a lower access to surgical care than the national standard overall for at a SPAR less than 1, which may be due to the large population in the region hypothetically overwhelming the capabilities of the hospital systems in that region. However, you can start seeing that in the Midwest, as you head towards the West, the United States, we see a major overall decrease of surgical access with larger pockets of decreased access, which might also be due to, in part, to the lower population living in these areas, as well as the lower number of hospitals. So the study found that nearly 10% of Americans experience low spatial access to emergency surgical care, and about 21% of the US population experiences low access to hospital with advanced surgical need, those for complex surgical cases. This estimate is greater than those previously reported by studies utilizing only driving distances and time as a measurement. So living in a rural community is significantly associated with low access to emergency surgical care. However, small area analysis revealed that insurance status continues to be a significant factor associated with access to care across all settings. However, racial and ethnic minority status was further associated with low access to care in micropolitan and rural regions. In metropolitan areas, racial and ethnic minority communities tend to experience more favorable access to surgical hospitals than predominantly rural white communities. Again, these minorities tend to experience less than favorable access to surgical care when living in similar predominantly white communities. So insurance, as previous studies have shown, remains a consistent factor in healthcare and healthcare access. Being uninsured or having public insurance like Medicaid or Medicare increases your association with having lower access to surgical care in all settings. Something else that the study authors discuss is how hospital closures and surgical center closures affect population, including disproportionately affecting those in urban regions as travel distances increase. Of course, there are limitations to these methods, to the use of enhanced two-step floating catchment area models, as this is based on the average of the entire region that's being assessed, which unfortunately are those at greater risk that get missed, meaning that if there is a large outlier in the positive direction, it may mask disparities. Also, the American Hospital Association annual surveys based on self-reported responses from hospital administrators, which may vary from actual statistics and capabilities of hospitals. Just because the hospital does have surgical capabilities, or is classified as a surgical capable center, it does not mean that the surgeons are available or that there is enough staff to cover all cases. So in conclusion, this cross-sectional study of spatial access to hospitals with emergency surgical capabilities using the SPAR method found that about 10% of US residents experience low access to emergency surgical care, and about 21 to 25% have limitations to access to hospitals that treat complex surgical emergencies. So although insurance status was a factor associated with low access across all settings, racial and ethnic minority communities in micropolitan and rural areas experienced the greatest risk of limited access to surgical care. These findings support the use of the enhanced two-step floating catchment area model of SPAR in identifying areas with low access to surgical care. However, further testing with these methods needs to be performed to validate generalizability. Future multivariate analysis that separately address rural and urban populations and adjust for population demographics are needed to approximately address health disparities in the US. All right. I know I ran a little quick just for sake of time, but yeah, does anybody have any questions?
Thank you, student Dr. Bahamon. That was a great presentation. Dr. Zard, go ahead.
I think you're muted, Dr. Zard.
There we go. Can you hear me now? All right. Help me with this because, you know, I'm looking at the Joplin campus, how the Joplin campus came about. We've been in business now, what, 7 years now? And the idea, as I understand it, was to produce physicians in areas where there is not a lot of medical access. And obviously other schools are doing the same thing. Examples of Wichita, example is the Walton School down in Arkansas. Is the idea to produce a significant number of physicians in these rural areas with the possibility of developing an emergency hospital situation where it goes from that kind of blue to, I'm sorry, from the red to the blue, where we have access to, in other words, the idea is to increase the physician population. Does that in turn, the wishful idea is to create a hospital situation that can address better healthcare access to these folks?
Yeah, so something that I'm interested in studying is the increase of rural surgical care. And, you know, I think the United States is moving towards a positive trend of producing rural physicians. However, what we need to look at is that majority of these physicians are non-surgical physicians. And for, you know, surgical physicians, they tend, whenever they graduate, to move to urban areas, therefore creating condensed surgical centers where rural spaces are missed. And it, you know, I think we do really good here at Joplin, especially, how with increasing rural care. However, if you look at the statistics, about 70% of our students go into primary care. So the goal of this study was to assess, you know, the surgical care of it. And, you know, there is good amount of transfers that happen between hospitals whenever patients do present surgically. But the overall surgical access is decreased in you know, in the rural areas, and as seen in the study, in urban areas, based on basically your insurance as well as your race and ethnicity. So yeah, we're heading a good way towards increasing rural, but I think, you know, changing the paradigm to also include surgical care. And there's a lot of obstacles from other previous studies that I've reviewed. If you look at federal grants and loan forgiveness as an example, majority of states provide rural primary care loan refunds to kind of incentivize physicians to stay in the area. However, not many include surgical specialties, and that's one of the missing pieces of puzzle that I think, you know, we need to look at for public health.
Thank you.
Student Dr. Bahamon, are you thinking surgery as a specialty after you graduate med school?
Yeah, it's on the table. I'm very interested in it. I think, general surgery. I would love to increase rural care. And maybe if I do go that route, I would love to practice part-time in kind of like an urban center to maintain skills, and then also see if I can join a group or set up a group that we rotate throughout rural clinics to increase that access.
Awesome.
But yeah,
I'm sorry, Dr. J, go ahead.
Student Dr. Bahamon, excellent presentation. Thank you. My question to you is, put on your thinking cap and look at it retrospectively. What is it that surprised you as you took on this study? That's my question.
Yeah, one of the biggest surprises that I saw on this is we're also experiencing decreased access to surgical care in urban areas. I think when the authors began with this study, they were looking at how rural care is, or rural regions are affected.
Yeah.
But, there is almost an equal decrease of surgical access when you account for ethnicity, race, and insurance status.
Yes.
So a person of color who is underinsured will have basically the same level of access as a rural white person who is insured. So there's still a lot to look into and to find out what the discrepancies and what are the confounding factors to this.
All right. Thank you. Enjoyed your presentation.
Thank you.
Soon, Dr. Tucker, go ahead.
Thank you. Great presentation, student Dr. Bahamon. I just had a question. I recently heard in the news that Missouri will be paying back loans for students that graduate from medical school and proceed to practice primary care in rural parts of the state. But I noticed that they don't pay for students that want to go into surgery to then practice in rural areas. Do you know of any other states that may actually pay off student loans for surgery residents, and why wouldn't they do that in Missouri?
Yeah, I think that's really interesting question. And our neighbor Oklahoma actually does provide kind of like a loan forgiveness for surgical specialties, general surgery specialty, which is interesting that they're applying that just west of us. But it comes down to funding and these kind of studies that demonstrate the disparities that are felt across not just primary care but the surgical treatment. And I'm interested in political advocacy to increase that as well. I think Missouri would be a state that would benefit from also providing some sort of financial incentives for physicians. If you think about it, 5 years of residency for general surgery, I think that's what drives some of these surgeons to go into urban areas where they might have a greater income in some cases. So.
That's crazy. Why would you want to disincentivize rural or urban surgeons? I don't get it. Dr. Wolf, go ahead.